And I want to thank everybody who's joined us. We do have the final topic for our legislative panel today. And this one here is on mental health and foster care. And we're talking about the unmet needs and untapped opportunity. So we're going to ask our panel to come on up. Okay, and as our panelists come down and get settled there, I will take a moment and just introduce our first two. First, directly in front of me is Laura Maines. Laura is the Chief Executive Officer of Every Child, incorporated since 2014. She's the Vice Chair of the Board, Chair of the Public Policy Committee, and the Western Region Chair for the Pennsylvania Council for Child, Youth, and Family Services. She's a passionate advocate for children who is working to ensure that there are sustainable, high-quality services so that each child and every child has the opportunity to thrive. Laura's testified with us before at the summit. Very much appreciate her and Every Child. Always been a partnering organization for us, so thank you. And then, of course, we have Mary Carroll. Mary has been a foster parent for the past 4 years for Every Child, along with her partner, Lee. Mary has had firsthand experience with the challenges of trying to access and ensure that there is a continuity of quality mental health care for youth while in her care. So we very much, I know being a foster parent is a challenging work. So we thank you and Lee for all your efforts. And obviously, we're going to get into those mental health issues that perhaps are more common in certain settings. And that's why we want to talk foster care. So we'll go to Laura. Okay. Thank you, Laura. Go ahead.
Are we good now? Oh, there we go. Okay. Thank you very much. Good afternoon to all the members of the legislative panel. Thank you for making the time to be a part of this important discussion. I have a poster that hangs in my office with a quote from Nelson Mandela that says, "There can be no keener revelation of a society's soul than the way in which it treats its children." And I think we can all agree by that measure, we have a lot of work to do. I could give you a litany of fixes for foster care, but since we're only talking about mental health today, I'm going to try and focus on that. There are almost 20,000 kids in foster care in the state of Pennsylvania, 400,000 nationwide. And despite a growing recognition that mental health is essential for a child's healthy development and overall well-being, it remains the single least met need for all kids in foster care. And there are a number of reasons for that, and we're going to talk about that today. This panel is going to talk about what those mental health needs look like. We're going to talk a lot about the barriers to meeting those needs. And we do have some suggestions for making some changes to make sure that we can do better for kids in Pennsylvania. So what I want to say is, first of all, understanding the problem can really fall into three primary categories. The first is going to be recognition of what the need is. The second is going to be, I'm categorizing that as communication of needs and access to treatment. And then the final is going to be continuity of care and prioritizing mental health in the same way that we do meeting immediate needs, health care, housing, food, education. Mental health frequently falls to the bottom of that list when we're talking about healthcare. So recognition of the need. You can all probably imagine that just by the fact that a child is removed from a familiar surrounding, from a familiar caregiver, regardless of whether that was a healthy and safe caregiver, is a traumatic event. So 20,000 kids in foster care in Pennsylvania, 20,000 kids have experienced a significant trauma. And that's before we even get into what were the circumstances that led to that child's placement in out-of-home care. That could be physical abuse, that could be emotional abuse, sexual abuse. It could be exposure to domestic violence, drug and alcohol challenges. There's a huge list of reasons that a child may be removed. All of those also traumatize a child. So we know that. There's no one that would disagree that that's what's facing kids coming into care. And yet, in Pennsylvania, there is no county that requires a mental health assessment upon intake into care. This really shocked me. Every Child provides services in Washington, Westmoreland, Allegheny County. We take kids from all over the state occasionally. And Allegheny County is the only county in Western Pennsylvania that requires a physical upon intake. So when a child comes into care in Allegheny County, They typically will be taken to Children's Hospital for a physical evaluation. But no county requires a mental health evaluation despite our understanding of the trauma that a child has just gone through. And we know, if we look at our statistics for foster care, kids in foster care have a much higher rate of diagnosis of mental health issues than the general population. In fact, 80% of kids in care have a mental health diagnosis, as opposed to 20% in the general population. So again, we know the problems here. So why can't we do more? And again, those barriers are going to fall under that idea of communication and access. So we know that 60 to 80% of children with severe mental health conditions will demonstrate a positive response to therapeutic treatment. However, less than 25% of kids in care receive mental health or therapeutic treatment in their first year of care. One of the reasons for that is coming into care is a chaotic situation, right? We are bringing kids in an emergency. And so there is a lack of communication around what that child may have been receiving, either in their initial foster placement or in their family of origin, what their needs are. Records take a long time to transfer. And so when we are taking a child into care, and you'll hear from our foster parent, they often don't know if there is a mental health diagnosis. Are there psychotropic meds that have been prescribed? Do they have enough meds to get to the next appointment? What's the treatment modality? And so that communication and access right off the bat creates some real problems. You know, there's also a system vacuum. When a child comes into care, I think we've overcorrected to allow for privacy, to allow for privacy of the biological parent as well. Information is not widely shared. And you'll hear from Kelly Swift from CASA about how difficult it is for the CASA advocate to share information with mental health providers. They need to go and get a court order to do that. And so there are some simple changes that can be made to correct this, but the barriers, particularly around communication, every single person on a foster kiddo's case has a piece of the puzzle, but there's not a good mechanism for putting all the pieces together to get the full picture and then do an adequate needs assessment. So that's certainly a pretty large issue. We also know that foster parents are provided with very little information. Exacerbating that problem is they also don't have the authority to seek an evaluation on their own, even though they may be the ones that are seeing the behaviors that are raising red flags. So just to give you an example, if a child falls off their bike when they're in foster care, that foster parent can take them to MedExpress right away, right? They have a notification requirement, they notify their agency, they notify CYF, but they are empowered to take that child to MedExpress to get treated. The same is not true of mental health care. So when we talk about parity, we don't have it in foster care. And it's really creating some barriers to accessing treatment. The other issue you're going to hear a lot about, it sort of falls under that continuity of care and prioritizing mental health. When kids are in foster care, their mental health services are paid for by medical assistants. That puts them solidly in the managed care realm, right? And if you know anything about managed care, it is geographically driven. So if a child is originally from Washington County, they are going to be on, I'm going to say Beacon. They have a different name now, but it's like their fourth name in 4 years. So we'll just say Beacon as the most recent managed care organization. It's Carillon, yeah. So they'll be with that managed care organization. If they are placed in a foster home in Allegheny County, which happens fairly frequently, Allegheny County uses Community Care Behavioral Health as their managed care organization. So just from a move 10 miles up the road, now we have a lot more paperwork to transfer, we have additional approvals to get, there's no guarantee that the provider that they may have been seeing in Washington County accepts community care or is a preferred provider by community care. And we're not even getting into the situation of having a teenager who might go away to college, right? And how are they gonna pay for ongoing mental health care? Now they're living somewhere else. They may not be able to access a provider that's covered by their insurance. So that logistical barrier really creates, again, some significant issues. And as I've said, you know, Mental health treatment for foster kids is just not prioritized. We are bringing kids in and we're trying to keep them safe, and so we make sure that they have a bed to sleep in. We talk a lot about kids sleeping in CYF offices. That needs to be corrected. But mental health is just as important. We know that youth in foster care experience PTSD at 2 times the rate of U.S. war veterans. Youth in foster care are 3 to 13 times more likely to be prescribed psychotropic medications. And so then when we talk about the difficulty of continuity of care, how are you maintaining those medications if you're going to provider to provider to provider? How do those providers know what reaction you may have had to that medication if they haven't seen you before? It creates lots and lots of challenges. And we also know that untreated mental health challenges create instability in foster care placements. And every time a child is moved, it re-traumatizes that child. So when you have untreated mental health issues in the home, it creates chaos in the foster home. As a foster care agency, we get a call saying, we're sorry, we really can't manage this. It's just too much for our family. That child gets moved to another home, and we start the clock again. And we know that 90% of youth that have 5 or more foster care placements during their time will end up in the juvenile justice system. It's unconscionable. And the problem that I'm talking to you about today is not a foster care problem. Let me be really, really clear about that. This is a community problem. These are our kids. They're not their kids. They're not kids from over there. They're your neighbor's kids. They're your sister's kids. They go to school with your kids. This is our problem collectively. And too often, they don't get the attention that they deserve, and they fly under the radar. So I really appreciate all of your time in being willing to hear what the challenges are. To end my portion on a high note, there are some simple things that we can do. First and foremost, let's evaluate every kid. Let's do a simple trauma assessment every time a kid comes into care, and let's do it every time they change placement. It's not that hard to implement. Every child has done it on our own. So every child that comes into care with us, we do a trauma assessment. But man, it sure would be nice to have a statewide standard assessment that really allows for that continuity of care. Look, it shouldn't matter how a kiddo's outcome, a kid's outcome should not be dependent upon what county they've been taken into foster care. It shouldn't be dependent upon who their caseworker is. It shouldn't be dependent upon who their judge is. And it is right now. And so let's just start with a simple assessment. Then let's say who needs to know about this kid and clear out the barriers for sharing information. We can protect privacy, but also be transparent and make sure that everyone knows what a kiddo needs, all of us who are responsible for their care. That's pretty straightforward. Increased training and support for foster families is really important as well. At the end of the day, though, it comes down to policymakers and community leaders need to prioritize adopting a culturally responsive, trauma-informed, and holistic approach to supporting the needs of kids in foster care. We like to talk a lot about being a child-first system. We are not. We are not. But we can be if we work together. Thank you very much.
Great, thank you, Laura. And let's go to Mary.
Hi, everyone. Thank you for having me here today. And thank you to Laura for asking me to be here. My spouse, yes, loud enough? Yeah, sure. Yeah. So my name is Mary Carroll, and my spouse and I were certified as foster parents in March of 2020. So on our front porch, signing the papers with our masks on. And our very first call that we received was for a 14-year-old who was hospitalized after multiple self-harm and suicidal behaviors. We heard just a few things about this non-binary, transmasculine teen who loved art, music, and animals, and we just had a feeling that we'd connect with them. They transitioned, so they had been in multiple placements, foster care, and multiple hospitalizations before that. They transitioned to a residential treatment facility, which I'll refer to as an RTF after this. And we spent the next 9 months getting to know them as they stabilized at the RTF. We did family therapy sessions to get to know each other and establish household rules and roles that would work for everyone. They were able to meet their goals, but couldn't get discharged without a psychiatrist set up for medication management, which we were told to do on short notice. We were panicking trying to get this set up so that they could be discharged to us by Christmas. We really wanted to have them home for Christmas. We called Personal Connections and eventually found a doctor. Finally, they were discharged on December 22nd. We were able to get set up with family-based therapy soon after they came to us through our foster agency, Every Child, which luckily had this service and was one of the reasons we had selected them as our agency. Not every agency has that. Getting an individual therapist proved a lot more challenging, and it was only when one of the family-based therapists transitioned to another nonprofit practice that we were able to follow her there with our child. The main reason was lack of LGBTQIA+ competent providers who took our teens' behavioral health insurance, which was from Washington County, CYS. Luckily, COVID made telehealth options available for medication management, but eventually the contract with a fantastic psychiatrist from Michigan ended, and we had to find new med management options, which was disappointing to say the least. Having done a complete intake and then meeting with a psychiatrist who forgets that your child is in foster care and makes insensitive comments about adoption makes it really difficult for anyone to trust them. We also did a ton of advocating for our teens, with our teens' caseworkers, lawyers, and judge to get them access to gender-affirming treatments like hormone blockers and testosterone. And then after that, we did lots of calls with insurance companies and care coordinators to get this medication to them. Many people needed education on the fact that trans healthcare is mental health care for LGBTQ teens who are struggling with severe gender dysphoria on top of attachment trauma and PTSD. Our kid graduated high school and is currently in college. And while we are proud of them for utilizing the school's counseling services, there was a total disconnection from behavioral health services when they moved out of the group home that they lived in between our house and college. There was a lack of support from the group home and other service providers to get them established elsewhere. Right now, they're on wait lists trying to get reconnected with individual therapy. They're willing to do virtual therapy, even though they don't love it. When you have a child born into foster care who has lived within the system most of their life, who is finally open to trauma therapy, insurance shouldn't be a barrier for that. So this is part 2 of my story. So after our oldest went to live in a group home in Philadelphia, we accepted a placement of 2 young sisters who both had developmental delays due to neglect. The older sister had more severe speech delays and had been diagnosed with mild intellectual disability. And we received on her referral, it said, rule out autism. We took that as a directive and we sought out services for both kids. And like Laura said, you have to kind of go through the channels to get other people to be on board with all those evaluations. They were in need of trauma therapy, so we got on a wait list for 16 months to get them specialized therapy they needed. In the meantime, we did play therapy, started with another agency to get them used to what therapy was like. We also eventually realized that both kids were exhibiting symptoms of ADHD, and we desperately needed support so that they could sleep, stay safe, and function in school and childcare settings. So we got consults from their pediatricians. Again, that took months. For one child, the parents didn't want to accept this diagnosis, so we had to seek additional evaluation and even get a court order. The entire process took us probably from September to January. We were on a wait list for a year to get the older sister seen for a neuropsychological evaluation that finally was able to rule out autism and told us that many of the behaviors she exhibited were caused by neglect rather than autism. We were not aware that neglect can induce autism-like symptoms in children, and we learned a lot from this evaluation. It helped us get her a one-on-one support at school, where she is still really struggling this year due to staff turnover. my spouse was called to go to school and pick her up right before I came here due to behavioral challenges. And just her trauma is being triggered by other children. So our current challenge is trying to get a behavioral health technician to support her behaviorally in different environments. We have a prescription for this that I've actually had for over a year. And I have done some case management on my own, but being that it's a different county's insurance, it became clear that it would be a full-time job for me to do that. Some organizations have no wait lists. You have to call them back every 30 days just to be considered to see where you're at, and there's no true list. So it's just pure persistence if you can find these services. So we get the help. So we got the help of Washington County's behavioral health coordinator to send out referrals. And it's been a few months, but we haven't heard anything back yet. Still waiting on that. Another frustrating thing is that even if we obtain a behavioral health technician and we're able to get our child into a specialized extended school year program, which is summer school, since she's struggled behaviorally in the school's extended school year program and other camps in the past, we were told that we can't have that person go to the ESY program, the extended school year program, with her because of how it could potentially be double dipping through insurance if she attends a specialized camp. Now, we're not sure what our options are, and we may be stuck hiring a babysitter for her if she's not able to function in other summer programs. Meanwhile, academically, she falls further behind, which if you saw her, you would think she's just like the sweetest little person. She'd come up and hug you, and she just lights up the room. You know, you don't know that she's struggling all the time. We have registered her with the Office of Developmental Supports, which used to be IDD, I believe, and although everyone says it's great for them to be enrolled at a young age, we're still kind of trying to figure out how to utilize them now. We faced many other challenges besides the ones I've already mentioned. Medication shortages, ADHD medication, hormone blockers have been some of the things that we've come up against. Having to search for behavioral health interventions on our own. You know, it's hard to be an amateur psychologist when you have a full-time job. And, you know, trying to find interventions when we didn't have professional support. We struggle, like Laura was saying, to get accurate, consistent information on supports, children's histories, and case updates. Our strategy has been ask 3 people. So usually if you ask 3 people, you'll have a general idea, some consensus on some information. So we'll ask a caseworker, the CASA worker, legal lawyers, mental health providers, the pediatricians in order to get information and make informed decisions, which we have to get approved, everything get approved. So 3 weeks after the sisters came to us, so this is another layer, my spouse was diagnosed with cancer, and in the next year had chemo, radiation, and 2 surgeries. He's doing well now, but it's also important to recognize that foster families do not operate in isolation and face the same crises as other families. In some ways, the kids coming to us at that time was a blessing because I had no time to be anxious about my spouse's health, and we were forced to take everything day by day. In other ways, it was very challenging to meet everyone's needs. Our family is privileged and educated. My spouse works for the Department of Human Services. I'm a nurse with experience as a home visiting nurse for the Allegheny County Health Department. We have a supportive network of family, friends, and stable finances. We embrace mental health supports for ourselves and have a wonderful couples therapist who herself is an adoptive parent and adoptive parent of a child from foster care. We have several other foster families that we connect with and support each other, but it's still not easy, and there's a lot that policy and lawmakers can do to ease the strain on families. All children in foster care deserve access to appropriate mental health providers, and streamlining behavioral health services to increase and to create an inter-county system and services would increase access to these much needed services. Thank you.
Thank you. Thank you both. Thank you, Mary, for sharing so much. So I'll just pause before we switch up for any questions. I do want to go to Laura. So your example was that a foster care, I'm sorry, a foster parent has been given the ability to address a physical need, right? Like in reality, if somebody fell off a bike and broke an arm, and the foster parent did not seek care, most likely the child would be removed from the foster care.
I mean, yes and no. That's where it falls under the idea of reasonable and prudent parenting, which was some legislation that went through, gosh, I want to say maybe 8 years ago at this point. We go through a lot of training with our staff. But the idea was to try and break down barriers for decision-making for foster parents. And that extends to, does the kid need medical care? Can the kid go to a sleepover with their friends? Those typical decisions that parents make for their kids every day, foster parents should be able to make. So that's true when it comes to physical health care. And so there are times when they may make the determination that this is a Band-Aid's going to fix this and it's going to be fine, right? And they're not going to have that child removed. But they have the ability to make that determination based on what they're seeing firsthand. And when it comes to mental health care, the same standard is not being applied. If they want a child to get an evaluation, we had one circumstance at our agency where we had a foster parent who was really frustrated because a child that had been placed with her ran out of his psychotropic meds. And she didn't know if he still needed them. She didn't know if the dosage was right. She couldn't get her prescription refilled because he needed an evaluation. The biological parent wouldn't respond. The caseworker wouldn't respond. And so she went ahead and scheduled one. And that child did get removed from her care for a period of time. We had to fight to get him back with that parent. And I'm happy to say he's still with her and doing well. But those are the kinds of things that really defy logic.
Well, yeah, but like a broken arm, right, should be addressed. So I guess my point being is that so when a child is placed in a foster placement, right, then whose overall responsibility is it for the welfare of the child?
It's a team effort, right? They're technically in custody of CYF, legal custody of CYF, right? And the state has a responsibility in that regard. And I would also say,
but the CYF can only get the child because the state allows the child to be removed, right? So I mean, so I guess my point is that the kids are, if they're removed, they're wards of the state.
That's right. Yes.
Right. Mm-hmm. Okay. So wards of the state, physical care gets met. Mm-hmm. The mental health needs Mary can't address.
That's correct. That's correct. And I would say a mental health crisis is as serious, in some cases, if not more so, than a broken arm.
Emily?
So I think that this is something that we don't really talk about, and it's really important, and I appreciate Representative Miller for putting this together. What I think we are starting to realize as a society is that adverse childhood experiences are something that you carry with you into adulthood and can actually cause significant issues as adults. What recent studies, and I'm sure you probably know this, is that ACEs actually has been shown to have physical health manifestations in adulthood, increased cardiovascular issues, stroke, things that you wouldn't necessarily associate with sort of mental trauma are manifesting later in life as a higher likelihood of physical issues. As somebody who has a 5 out of 10 score for ACEs, it's something that I'm acutely aware of, that this becomes an issue where I'm at a higher risk of having a stroke for no other reason than just the way that the environment that I grew up in. Mm-hmm. And so, I guess I don't really have a question as much as a comment where, I've been actually working on legislation to require an ACEs screening in physicals for all kids that, so I'm hoping that, if at least if, we can address that part where if there is a required ACEs screening in all physicals for children, that, at the very least we are, at one, educating medical professionals to look for that kind of stuff, and two, if we are requiring a physical for foster kids, then, hopefully that stuff is, to a degree going to be caught to some extent. And because, the treatment for how we address ACEs, manifesting later in life is, addressing it now with therapy, with mental health treatment. And so I'm hoping that we can address that, because, no kid should be put in a position where, as an adult, just merely by the way that the environment they were raised in, have a higher likelihood of sudden death. That's, for all the things that kids go through that cause this kind of trauma, it shouldn't be an extra, impediment. So thank you.
Yeah, thank you.
Right, and I guess part of the question, the issue too, was that the physical screen isn't even required. That's just Allegheny County deciding to do it, right?
And, we're state funded and county administered, so you guys need to use your power of the purse and require some standardizations a little bit more across counties, right? That should be an easy thing. Every county should have a physical requirement, and every county should have a mental health evaluation. It's easy.
All right, don't get punchy. All right, any senator?
Yeah.
So the reason why, we have mental health parity legislation laws, right?
Yeah.
Is it because they're not required to have physicals? That means that we're exempt from doing physicals and mental? Or I'm just curious, and do other states require, in these circumstances, require a mental examination?
Some states do. Some states require both. And it's really, I think we're unique in Pennsylvania because of the way our system is set up, right? Because we are state funded but county administered, I will tell you, child welfare in the counties is a little bit like the wild, wild west, right? And that was really eye-opening for me when we expanded into Westmoreland County. No disrespect to Westmoreland County, but it gets real crazy. So that's part of the problem. I think the other part of the problem is it's really difficult to have a conversation with some of your colleagues on the other side of the aisle to talk about the fact that parity in care does not necessarily mean you have to blend the funding, right? And right now, the behavioral health carve-out is a really positive thing for Pennsylvania. It's a really positive thing for Pennsylvania kids. It allows us to meet local community needs. It allows us to innovate, to put different kinds of programs in school, all the things. And if you start blending that funding, that goes away. Reinvestment dollars go away, and innovation goes away. But it's been really difficult to have the conversation around parity in care without talking about the funding. I think that's probably the bigger barrier.
Okay, thank you. I know we have another presenter too. Mary, thank you. Okay, so like being a foster parent is tough, right? No matter the challenges that come. It sounds like, by the way, that you and your spouse have done everything humanly possible to be supportive, right? And so you're exactly the type of person who we need more of to be involved in the foster system. So thank you for everything you're doing, okay?
Thank you. Try not to burn me out.
Try not to burn her out. Okay, yes, thank you both. We have one more presenter, right? Yep. Yes. Kelly Swift is the executive director of CASA for Kids of Washington County. Her agency trains the community volunteers who have been appointed by juvenile courts to act as court-appointed special advocates, CASAs, with the role to advocate for the best interest of children by acting as objective fact finders for the court. Right? Sounds right? Is that okay?
Yes, thank
good.
you.
Very good. Kelly, thank you for being here.
Thank you for having me. Our young people are our greatest treasure here in the Commonwealth, and we're doing them disservice by not allowing the kids in foster care to be assessed right away for their trauma needs. I'm going to focus my talk on that. We know that 80% of the children in foster care are coming into foster care with at least one physical health problem. 60% have developmental disabilities. 80% come in with significant mental health needs. 20% have significant dental needs. And half of the youth in foster care have chronic medical problems related to behavioral concerns. So a common misconception is when a child gets placed into foster care that needs that weren't being met, all of a sudden will be met. And that's not the reality. As you heard Mary speak so clearly, that there are a lot of hurdles once that child is in foster care. A CASA volunteer is a community volunteer who's assigned by a judge in dependency court, who's given that judge's authority to get records regarding that child and to get to know that child by visiting with them at least once a month and creating a written report for the judge and all the parties in the hearing to understand the issues and focus their recommendations on what that child needs. CASA is in a unique position because the court order is not dependent on the parent releasing the record, and it's not dependent on the child releasing the record. It is based on the judge's authority in assigning the CASA. A CASA volunteer is a highly trained and highly screened individual. They receive professional support from CASA staff. They don't go to court on their own. Their reports are written as fact-based documents, and they're entered into evidence most times by the guardian ad litem on the case. There are CASA programs in Washington County, in Fayette County, in Westmoreland County, in Allegheny County, in our Southwest PA area, also Somerset and Cambria. But not every county has a CASA program. There is a state organization, PA CASA, that is working to expand CASAs into the counties where there aren't any currently. Your support of CASA helps ensure that kids who are involved in the system have their best shot of having their needs being brought to the court's attention and also to the attention of the other people involved on the case. But a CASA is constrained on how they release their information. So on my own case as a volunteer, my CASA child has had countless traumas. She has been in and out of foster care. She has experienced significant loss in her life. When she goes for an assessment, if she's in a foster home where they don't know that history, and if the parents aren't able or are not willing to participate in providing history to that evaluator, that person who's doing the mental health assessment doesn't have the background information that they need. And so as a CASA volunteer, I have to ask the judge, Your Honor, would you please write in the court order that I have permission to share background information for this assessment? And sometimes the judge does allow that to happen, but court only happens every 3 months typically. So there can be a lot of lulls in how that information gets shared. Sharing information is not necessarily the CASA's role. CYS should be sharing that collateral information with mental health evaluators so that kids' needs are met and so that that evaluation's not a waste of time. Everybody should have that background information so that that child gets their needs met when they're having a trauma assessment. And I do echo strongly what Laura said. Every child in care should be having a trauma assessment at the very base, along with a physical assessment when they enter into foster care. And I think it would go far to meet their needs. And the wait lists are very long for treatment, and our kids deserve better. If you had an acute mental health issue and you had to wait a year for treatment, that's a long time in a child's development, in a child's educational experience, that they've had to manage that without the care that they need. And unfortunately, that's not unusual for there to be significant wait times for kids. Thank you.
Okay, Rep?
Yeah, thank you for coming. We have CASA is over in Jersey, I mean Southeast PA. And we've met with some of your counterparts, and I know that there is a budget request that is in front of us all. So if any of my colleagues don't know about that, I'll let you know. I signed off on the letter that they're asking for. The interesting feature I found with CASA Volunteer is it's a single person with a single child or family caseload. In other words, it's not your standard situation that we see in the counties where a caseworker has multiple children and families, sometimes as many as 25 or more kids that they're trying to handle. And so that the volunteers' in-depth knowledge of the child's situation is really something that provides a unique perspective and a window for that child's voice to be heard. I'm wondering if you could speak a little bit to that experience.
Yes, thank you for bringing that up. I was so nervous I forgot to focus on that. But a CASA volunteer is only assigned to one child or one sibling group at a time. And they follow that case until it closes. They follow those children no matter where their placement changes. If they're returned to their parents, that's a wonderful outcome for children. And when a CASA is on, they stay and continue to assess and continue to support on the case no matter where that child is in child welfare. And in Washington County, our CYS caseworkers are carrying large caseloads, and they're at half capacity right now with their staff. So I think they're trying to fill half of the caseworker positions. And so they have large caseloads. A CASA only has one child or one sibling group that they stay with the whole time. So we have CASA volunteers that have been volunteers for 22 years in Washington County. Not on the same case for 22 years, but on their fifth case now, where they've stayed on for multiple years, and that person quickly becomes a consistent person. We require a 2-year commitment when they're becoming a CASA volunteer. They sign on with their volunteer commitment that they will be involved. And, within about 6 months on the case, there will be turnover in lots of other places on the case, but the CASA volunteer stays consistent. And our volunteers, on average, are staying with our program for 54 months. So though we require 24-month commitment, we're a good use of this training time and support that we give them because they continue on for more than double of that time serving as a CASA. Thank you.
Okay. Both you and Laura mentioned the physical and the mental health evaluations. So 20,000 kids with both physical and mental health evaluations that need to be done. So I guess there's two sort of thoughts there. One is, does the system have the capacity to do that? And then number two is, can we pass a cost on to you guys? No, CASA can't do it. So I'm just wondering when Sarah and Amarado's here tomorrow, right? So one way or the other, if we're doing that and it's going to cost, I don't know, $200 an eval, somebody help me with that?
I think it would be more than that.
Can we?
I do.
Can we do it? Can we do a bad job? What can we do? No. So all right. So I'm just saying, how do we deal with both the capacity question and the cost factor with that?
It's going to cost more and it's worth it. That's what I would say. It's worth. Think about your own family. If you want it for your family, then you should want it for every kid in the Commonwealth. And that's what a CASA volunteer is doing. They're taking that case and investing time, 10 to 15 hours a month, learning about that child, getting to know what their favorite color is. Her favorite color is purple. Her favorite food is a Reese's peanut butter cup. She's a good artist.
Do you know how long evals are taking now?
It depends on the type of eval, right? So you can can do a quick eval that costs $150. We're doing a trauma assessment right now. It's a 2-page questionnaire, and then we have a scoring mechanism. You get a particular score, and then you act accordingly. It doesn't have to be a psychiatrist. It could be a licensed clinical social worker doing the initial trauma evaluation. So I think your question is a little more complex, because we would need to look at what level of professional do we need to do the initial assessment, and then that would factor in the cost. I would say you could have someone at every CYF office whose job it is to do that assessment. You say they're going to be scheduled for an assessment within 48 hours of coming into care. If we're managing to take them to the ER to do it, we can certainly do it in the office. And I will tell you, Allegheny County had behavioral health coordinators in every office for a while. So this is something that is affordable. It's able to be done, and I would say is a much better spend than using AI to assess placement decisions.
Okay, Javi. All right. Other questions, Joe?
Whip. I mean, I know this isn't really where you were coming from, but when we pay for preventative care, preventative things up front, the back end costs to society are less. And I know you were playing devil's advocate there.
No, I meant it.
But yeah, I know you did.
No, look, it's Joe doesn't know it, but I was a county solicitor in Allegheny County for many years and did a lot of CYF cases. And we were, one of the challenges that we had, really, especially more on the delinquency side, was waiting for evals and the challenges that leaving kids sometimes out of home while we were waiting months, it seemed, for evals to be done. So
I think, I'm sorry, I didn't mean to cut you off, but I think there's a difference between sort of that initial treatment eval, and then some of what you're talking about relates to interactional evaluations, right? Where you're really doing a comprehensive deep dive into need. I mean, we're talking about triage here, and even triage isn't happening.
Right, gotcha. Thank you. Okay. So I want to thank you, Kelly. Thank you for testifying. Laura, nobody told you to come back up. I don't even know what you're jumping back over the tail, but it's fine. Look, I want to thank all of our testifiers in reality for it, and I want to pause while we have a moment, and I just want to go down the line to my friends and just give everybody a moment just to talk why they come, and I appreciate it. Senator Costa has been here for many years. Jay, we thank you. Tell us what's on your mind with mental health.
Well, thank you very much, Dan. No, I think I always enjoy coming because I learned so much, and I want to say thank you to hosting all of us and all the members and folks to come and learn more as we can. I learned today this whole conversation about the lack of mental health testing, whether it be a triage situation or more in-depth through the process type evaluation. And we have mental health parity laws in this Commonwealth, in this country. I'm surprised to learn that. So I think it's something that we need to take a look at. I agree with you. I agree with the previous speaker that every kid should be treated in an appropriate way, and I think that's what we're missing. And it's really to the comment that I think you made about how we treat our kids, society. We have to prioritize the space. I know we already did legislation putting $100 million into school safety programs and school mental health programs, but we got to find resources to be able to expand it into programs and particularly that assist the people who are stepping forward and volunteering their time and their efforts, and the organizations that people are taking in kids that have nowhere else to go in many instances. So thank you for your testimony and what I was able to learn. And then Dan, thank you again for hosting all of us and giving us the opportunity.
I am somebody who has mental health issues. I grew up in a household where my mom was profoundly mentally ill, and so I'm aware of these issues. And I think that the more that we talk about them, the better it is, because it also reduces the stigma around talking about mental health. And I really appreciate, and I want to say, can we all take a moment to thank all of the staff that have helped put this together? This is just really incredible.
Steph, they mean you.
Rep Miller, you put this together, your team puts this together every year, and every year we learn a lot of really important things about mental health, about disability, that we don't talk about, and we can't possibly as legislators be subject matter experts on everything. And so having a summit like this where we take a moment in time to dig into disability and mental health issues across our Commonwealth and talk about ways that we can do better and policies that we can create to make sure that we are, lifting up the people who are most vulnerable. It's incredibly important. And so I appreciate that everybody is here to make sure that we as legislators are educated and aware of issues. A lot of us did not know a lot of the concerns around the wheelchair issues and, around mental health care access in foster care. And the last time that we had the summit, we talked about, IEPs basically after kids graduate from high school. So, the continuum of care. And so I always learn, like Senator Costa said, I always learn something. And I think it makes us better legislators and better policymakers. So thank you.
Dan, I came here to steal your ideas. No, in all honesty, my first year as a legislator, my legislative assistant said, "You really got to go check out Dan's Disability Summit." He knew some of my predisposition toward these issues, and you've inspired me to do something similar, not the same, but something similar on the southeastern part of the state. So my motivation is centered around empowerment and the recognition of equality that really is the goal of increasing accessibility and increasing the services that are provided to people with disabilities. It's really enabling that community to recognize its own voice and own power, and we will all reap the benefits as a result. So that's why I'm in this.
Thank you. I want to echo everyone's sentiments. Rep Miller, thank you for your leadership and your advocacy on this issue, not just here locally, but everything that you do up in Harrisburg as well. This is my second time attending this conference, the summit. I am amazed at both times, really the complexity of the issues and how layered that they really are, and realizing that the solutions to those things get very complex as well. And you try to solve one issue, but there's 10 other issues that are intrinsically connected and tied to that, right? And so as legislators and hopefully practitioners of pragmatic policymaking, I think that hearing from folks like you all really is helpful for us to say, how can we take your words and put it on a piece of paper to make it into a law, to improve the quality of life of everybody. Like that's part of our job. And so I just, I thank you all for what you're doing and the advocacy that you put forward. For me, I am really interested around the mental health piece in foster care and trying to figure out how we can have some uniformity across the state, as you mentioned, and understanding how other states who have done it, how they've done it well, what lessons learned, things they might have done differently, the cost, things of that nature. And then also, I'm interested to learn more about, when it comes to wheelchairs, the advancement in the technology to help people in terms of understanding when their wheelchair might be in a space where it's going to break down, right, to have that preventative actions. And so I thank you all, and thank you, Rep Miller, for having me. Appreciate it.
We cannot effectively legislate unless we actually hear from people. It's an impossible task. I was at one of the sessions at 1 o'clock, and just hearing our foster mother speaking today really made me understand what a constituent was telling me a few weeks ago about he and his wife are foster parents and what they were going through. And I kind of understood it as a lawyer, but I didn't fully understand it now until I heard from you and from the professionals I heard from before. So I thank you for that. And Dan, I've been coming here, I think before I was elected, you invited me to come here. And so that was about 9 years ago. And it's just been a wonderful experience each time. Thank you.
As someone who came out of the disability and mental health space before being elected, it's always nice to have the opportunity to return to my roots. So I appreciate Whip Miller for including me as part of this. I always learn something new. And I think no matter how deep your feet are planted in the disability space, conversations like this are ones where you always learn something new. And so I'm grateful for that, and in particular, as a queer woman, I am particularly grateful for folks in the foster care space who make the effort, despite lack of resources, to create safe and welcoming spaces for LGBTQ plus young people. And at a time where we're having conversations in the State House about what makes someone have capacity or incapacity to serve, I think conversations like this are critically important. Thank you all.
Thank you, Jess, and thank you, everyone. Let me go over a couple things. I know Steph is telling me I got to wrap it up. So, look, first off, I want to thank again all the presenters who came and gave us information and really shared some stories. You could tell that it is something that every one of my friends and I are going to be thinking about and trying to see how we can improve the system. So, again, thank you for doing that. I want to thank all my colleagues. I want to thank a couple people before I let you go. First off, look at this woman. Come on. She's been doing this for I don't even know, 7 hours, I think. So thank you to all of our interpreters who keep our program accessible. It's fantastic. Again, I want to thank Bethel. I want to acknowledge everybody who helped make this event work. Highmark Whole Care, St. Clair Health, UPMC, Unique Source, FISA, Allegheny Conference. I want to thank Every Child for their support, 13 Ball, Lamar, Eaton Park. Are those cookies gone? They're gone. All right. Well, okay. And all the volunteers that really helped make it work. Look, we have our partnership with Band Together Pittsburgh, our Creative Citizen Studios, and a whole bunch of friends who continue to try to help us push the envelope into something new every year. We only do that really because of the volunteers who help it make it work, the organizations who help us try to make it engaging, and the people who keep coming with the hope that together we're going to make something better for people as far as opportunities for everyone.